Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to this episode of the Gastro Girl podcast. This is a special edition episode produced in collaboration with the American College of Gastroenterology's Patient Care Committee. And today we're joined again by the amazing gastroenterologist from Duke University, Dr. Justin Crocker. Welcome, Dr. Crocker.
Thank you. Thanks for having me. Good to see you again. And I'm happy to be here to
Good to see you.
talk about all these amazing drug options we have available for IBD.
Yeah, so this episode, we're going to focus on treatment options and updates in inflammatory bowel disease, otherwise known as IBD. So for those listeners who maybe hit our episode without watching previous episodes, just give us a brief description of what IBD is and what are some of the common symptoms and experiences for patients that are living with it.
Sure. So IBD is by definition an inflammation of the GI tract. So it's in the name, inflammatory bowel. Some people get it mixed up with irritable bowel, which is IBS. They're two totally different things. IBD, which is inflammation, has two main kinds. People may be familiar with the terms Crohn's disease and another term called ulcerative colitis. And those two things are vastly different from each other. They're similar, but they're also different. And they're different enough to where a lot of the drugs that are out there may be for one, maybe for the other, or maybe for both. So it's important to know which kind of IBD you might have. Symptoms are typically include diarrhea, blood in the stool, abdominal pain. Those are the main symptoms that someone might be seeing if they're having IBD. But IBD is an autoimmune condition, so it affects the GI tract, but not only the GI tract. Sometimes it affects other parts of the body too. People can have joint pains and rashes and eye inflammation, and so the IBD is kind of a whole body problem, although the bulk of the problem is in the GI tract. So that's what IBD is, and it is one of these things where there's no one single test to just say, hey, the tests came back and said you have it. It's not like that. It's not like a pregnancy test where you either are positive or negative. This is a more convoluted condition that doesn't always present itself immediately with just one test. And so it can be challenging to make the diagnosis in some people. There's a lot of GI tract to look through to see if that's what's going on. And so we like to have very, very good confirmation through a variety of tests, colonoscopies, x-rays, and things, to feel very confident this is the diagnosis before we take the plunge and put people on medications.
And the two most common forms of IBD are Crohn's disease and ulcerative colitis, correct?
That's correct. One affects just the colon, and then that's ulcerative colitis. And then the other, Crohn's disease, can also affect just the colon, but it can affect anywhere throughout the entire GI tract. So it's kind of a catch-all. It can involve the small intestine. It can involve around your bottom. It can be up in the stomach potentially. So it's got a few hiding spots it can be in. Whereas the colon, we can easily see the whole colon during colonoscopies. So if ulcerative colitis is there, we'll see it. But Crohn's may not be there. It may be elsewhere. That's why Crohn's is the trickier of the two to nail down as the actual problem that's going on for someone.
Yes. So thank you for that brief overview. And, one of the most challenging, from the patient perspective, one of the most challenging aspect is management of this chronic disease. And one of the biggest questions we always get is treatment options. And there have been numerous advances in IBD treatments over the last few years. And that's why you're here today, because you need to help us make sense of this all so that our patients and anyone listening, a caregiver, has some understanding of what's out there, what may be something that they could talk to their doctor about for them personally, because there is no one size fits all. So we really need your help, Dr. Crocker. So if you could please help us make sense, we'll start with what are the current standard treatment options in terms of the guidelines that are options for IBD?
Yeah, when you look at the guidelines, they are they're not very specific in saying you must start with this drug first and only this drug first, and then move on to this drug second. It's not a It's not an algorithm or a cookbook recipe kind of a thing where we all start everyone at the same drug first and move on from there. The guidelines will say you can start with this drug or that drug or this drug or that drug. And if those fail, move on to this drug or that drug. So the guidelines give us all flexibility to do what we feel is best for the patient. So when choosing a drug for IBD, we take an individual approach. Every case is different. So it's a case by case thing. And the factors that are normally being taken into account is, of course, the obvious one is, well, what kind of IBD do you have? Because there's a drug that's only available for ulcerative colitis and you have Crohn's disease. Well, that's going to be a problem. Insurance companies like to put people on, like to cover drugs that actually have FDA approval for what you're trying to use it for, and not the opposite, which is where it's being used off label. So, what kind of IBD do you have? That's an easy one, usually. But beyond that, then it's like, okay, well, how bad is this IBD? That's the next big thing we like to ask ourselves is this mild and can be treated with what we call conventional treatments, which are anti-inflammatories and steroids and some mild things that are all in pill form? Or is this moderately severe or very severe? We're talking pretty intense inflammation that stuff's just not going to help with. And that's when we start talking about these things called advanced therapies, biologic therapies, or other terms people will use. Novel oral therapies, or other terms people use, because advanced therapies actually are suppressing the immune system in some way to get this inflammation to calm down. And traditionally, that's been with some drugs that people may be familiar with called Remicade or Humira. These are drugs that are both given via an IV or a shot that a patient gives themselves. And that's what has been traditionally started off with being used for IBD going back until around 2000 into 2010. That range was largely overseen by those two drugs, Remicade, Humira. That was what we had available to us. Do you want an IV? Do you want a shot? And that was kind of the easy deciding factor. But beyond that, we also take into account, do patients have other symptoms of their IBD that affects the joints and the eyes and the skin that some of these drugs may be helpful for too? Do they have any contraindications to them, meaning they have medical problems that may be worsened by these drugs? We kind of go through all the different side effects that can come from each of those. And questions that we should be asking patients are, do you have any history of cancers? Do you have any history of skin cancers in particular? Do you have any history of heart issues? Have you had any neurologic problems? These are questions that will help narrow that down. Other things will be, do you have other conditions that may benefit from one of these drugs? A lot of times people with inflammatory bowel disease don't just have one autoimmune condition. They can have an autoimmune condition like psoriasis or arthritis on top of it. And some of these drugs are more designed to treat those as well. And that would make a better sense to pick that drug than a drug that can't help psoriasis as well or can't help rheumatoid arthritis as well. So that's kind of a starting point for someone with Crohn's disease. And that's a lot of drugs that I just rattled off. But that's where we are right now, is the starting point. Here are the options, and let's continue to go down the pros and cons of each until we can find something that seems like the best fit for you.
And that's a really important point, because it is a shared decision-making process. It's not just the doctor saying, like you said, a guideline, okay, do this, do that next. There's so many other factors. There could be other comorbidities that, another condition that a patient has. So it's important that patients understand that it's not a one-size-fits-all approach, but to be educated in what's out there so you can ask informative questions and make the best decision for you with your healthcare provider's guidance as well. For Crohn's disease, how have treatment options evolved over the last few years, and what's new out there? If there's anything new that patients should be aware of.
Right. So in the last couple years, the newest drugs that came onto the market for Crohn's disease are called Skyrizi and another one called Rinvoq. Those are the brand names. Every drug has a generic name. I won't necessarily get into trying to say all of those, because these brand names are designed to be easily said for patients. And so those two are the newest we have for Crohn's disease. And what's unique about these is that they both work differently than what we've had ever before for Crohn's disease. So I'll start with Skyrizi. This is a cousin to a drug that's been around longer than it, called Stelara. So some people may be familiar with Stelara. And that was the first of its kind back in 2016 for Crohn's. And its cousin, Skyrizi, works very similar, but a little bit better, a little more honed in. So what we've done over the years, what makes all these new drugs different, particularly the biologics, is that when the anti-TNFs, that's the Remicade, the Humira, came out initially, they were kind of big umbrella drugs. They were tackling lots of different parts within the immune system, and therefore they can treat countless conditions that the immune system can cause. They can treat so many different things than just inflammatory bowel disease. As time's gone on, we've honed it down and down and down and down, and we've become very, very specific in where in the immune system do we want to target and kind of turn down. And that's what Skyrizi does, is it takes it one step further than what Stelara does, and is basically just blocking one particular part of the immune system, not two like Stelara does. And by doing that, what we have learned is it works better. You would think being more broad-based and covering all these different bases would work better. But we have found that if we really target the one that's truly responsible for this inflammation and turn that down, turn it off, then we can see big results while being safer. That's the other key piece with all these drugs, is that one assumption is, well, if it's better and stronger, then maybe that means it's more potent and riskier to me. It's going to suppress my immune system too much, and I'm vulnerable to infections and things, and it's just not worth it. And the opposite is holding true. The more specific we get in narrowing down where to block, that enables the rest of the immune system to be up and running, and therefore you're not taking on as many risks as you would be for something more global.
No, that makes sense. So are these biologics that you're talking about?
So Skyrizi is a biologic, and just to throw this out there, when we talk about advanced therapies, in the past that was synonymous with biologics because biologics were all that we had. And all a biologic means is that it's using the biology of some organism, typically a human. So it's taking proteins that are found in humans, and it's using those proteins to make the drug. And so that's what makes it biologic. And because these proteins are so big in size, and if you look at them under the microscope, they're ginormous compared to other chemicals. They can't be packaged in a pill. They have to be packaged in some sort of solution that you give directly through a shot into your skin or through an IV needle. They can't be a pill. And that's how these biologics or monoclonal antibodies or these immune suppression drugs have worked for many years for IBD and more. However, we now have these other advanced therapies that are pills. So they're not technically biologics. If they can be in a pill, it's not a biologic. But they're so potent that we've lumped them in with an advanced therapy category, and we're calling them novel oral treatments. And so that's what Xeljanz and Rinvoq are, and these others, Zeposia and Velsipity. All these pills that came on the market over the last several years fit into that category. So they're not biologics. Skyrizi that I just mentioned is, but anybody with moderately severe or very, very severe disease qualify for both kinds of advanced therapies, whether they be the pills, which are these novel oral treatments, or the traditional biologics, which are only given via shot or IV. So to keep it simple, we just still say all of these are advanced therapies, but they're not all necessarily biologics.
So if I was talking to my doctor and I was on, a standard treatment and I was not really doing that great anymore, and I wanted to learn about new treatments, the best way to say it would be I'm interested in some advanced therapies, to learn more about the advanced therapies that are, because there's so many new ones with small molecules and all of that I can't even remember all the names if I was a patient. So
Right.
it was
So the small molecule you mentioned is the opposite of that large molecule. So that protein that's so big that has to be in a biologic has its counterpart, as you mentioned, a smaller molecule that can be in a pill. Those are novel oral therapies, or as you mentioned, small molecules. But they're so potent that we've lumped them in as an advanced therapy. They're not considered a conventional therapy for the mild cases of IBD, like were first on the available to treat this condition long before biologics ever were discovered.
So what about the patients that have ulcerative colitis? Like, take us through, like you did with Crohn's disease, what we should know about, what's current, what's standard, and what are the more advanced therapies that have come up.
Sure. So ulcerative colitis has the benefit of a few more things that you can take than Crohn's disease does. So ulcerative colitis has a category of drugs now available to it that's unique to ulcerative colitis called S1P1 agonists. That's how they work, and that just means there's a receptor in our bodies called the S1P that these drugs work on, and that helps stop inflammation occurring in your GI tract. These two drugs, called Zeposia and Velsipity, are unique to ulcerative colitis, and therefore, if you have Crohn's disease, you're not a candidate for them. But they are pills. And so that's something that's interesting to patients who have been traditionally treated with pills and now they're failing and they need to move on to something better. This may be a good option for them because they can stick with what they know. They go from one pill to another pill. However, they aren't as potent of an anti-inflammatory as these other pills are for ulcerative colitis called JAK inhibitors, which one came out several years back called Xeljanz, and another one is on the market now called Rinvoq. Those pills are much more potent in terms of how strong they work, how well they can get inflammation under control, and how quick they can do it. But in exchange for that, there can be some more risks involved. So those pills can only be used if you have failed some sort of biologic, particularly an anti-TNF like Remicade or Humira first. Then you're eligible for that kind of pill. Whereas the S1P pills, Zeposia, Velsipity, you can have never taken a biologic before, you can have never failed something strong before, and you can go straight to those. So those are kind of known for as being the first and only pills that people can take that are considered advanced treatments without having to fail anything beforehand. So I can talk to patients about those pills. If they have failed some things before, the other pills called JAK inhibitors. And then if they're still anti-pill, it's like, listen, I would prefer to do something less frequent than a pill every single day. Then ulcerative colitis patients have the options of older drugs like Remicade and Humira. Entyvio is also now an older drug that is available for ulcerative colitis. And then some newer ones, Stelara, also for Crohn's, Skyrizi, just approved for ulcerative colitis recently, but also for Crohn's. And then one like those, but just for ulcerative colitis called Omvo or mirikizumab. So that's a lot of options. That's two anti-TNFs, the Entyvio, three anti-interleukins, two JAK inhibitors, and two S1P1. So you got 10 options for ulcerative colitis based on if you're brandly, just diagnosed, or if you've been struggling and you feel some things and you need to move on.
We don't have a ton of time left, and I don't wanna neglect saying that there's multi-factors that involve IBD treatment. It's not just a prescription drug, right? There's dietary, lifestyle, behavioral modification, stress. But I do, so we're not neglecting that. We'll definitely cover that in another episode. We wanna have a dietitian on to talk about dietary. So we're not ignoring that. We're kind of specifically talking about prescription drug options in this episode. But I do want to touch on the microbiome and advances in that. We've had interest in FMT, which is fecal microbiome transplantation. We had that whole documentary that came out earlier this year that caused a lot of discussion, and people were asking about it. What are patient options? Are there patient options right now for that more targeted treatment for patients and with the microbiome?
Right now, it's still not an approved therapy for treating IBD. It still just carries its approval for treating an infection called C. diff. that is refractory to multiple treatments, antibiotics, that's where that definitely can be approved, covered. For IBD, it's still in the research phase, so we don't have that available to us to get approved, paid for by the insurance company, and use, and not just necessarily because of an insurance hurdle, but still from a data hurdle. Um, you know, Treating IBD is one of these things where we perform evidence-based medicine. So we have the evidence from clinical trials and trials beyond that to help say these drugs do work. These drugs are what you should use. But the problem is that the data is comparing the drug to not taking the drug. So of course, the benchmark to meet for the drug is just how much better does it do than someone not on anything at all. And oftentimes you're going to see drugs do well in that scenario. That's why what we're moving towards is these head-to-head trials where we take an actual drug and pit it against another drug. And so no longer are we comparing it to placebo or not taking anything, but we're comparing it to something else that is known to also work. And now we can see who of the two wins that battle, who's the better of the two. That's more powerful data than continuing to try and find data on some of these other kind of alternative medicine routes to see how well they can work, because we're still struggling to see what does the data show on those things. And yet here we have very good data on two drugs, been FDA approved. It's gone through a rigorous process. It's now on the market for IBD. Let's do a study where we compare them two and see who comes out on top. And that's where the treatment landscape of IBD is heading, is more of these head-to-head drug trials so that we can triage better. And maybe we can come up with an algorithm that says, listen, we've now compared and contrasted this versus that, this versus that, and we have whittled down to where what's really rising to the top. And so right now the most recent of those studies pitted Stelara versus Skyrizi for Crohn's disease. These are two drugs that work very similar to each other. Skyrizi is more selective, therefore it's supposed to be better. And this study, called the Sequence study, showed just that yes, Skyrizi is better than Stelara in treating Crohn's disease. More people are getting into remission. There's no worse, if not the same or better, in terms of side effects. And so if you were to pick between the two, the data is showing from that study that Skyrizi appears superior to its counterpart, Stelara. And that's just one study. But what if we have a study that compares Rinvoq to Xeljanz in UC, or Zeposia to Velsipity in UC, or Skyrizi to one of those other drug classes in Crohn's disease, and we start doing all these head-to-heads, that kind of information is what's really, as it comes out, going to help make this whole conversation potentially get easier. Because now, instead of me just saying, well, you have all these drugs, they all do work. Some work a little better than others, but let's flip a coin. Now we have data that says, no, in reality, this drug, when compared to this drug in these same patients, is working better. So we should try and go with that. So unfortunately, we don't have the data yet or the approval yet to say things like FMT or bone marrow transplants or more aggressive kind of thinking outside of the box treatments to try and cure IBD, so to speak. We still just aren't there. Unfortunately, we're still relying on tried and true pharmaceutical companies doing clinical trials on these variety of agents and seeing, do they work? And then once we have said yes, okay, then how well do they work versus other things that have been out for a while?
No, and I'm glad you mentioned clinical trials. That's one of my next questions. Are there any promising clinical trials that you can tell us about? And what do you think about patients who are interested in getting involved in the trials?
Yeah, so that's the exciting thing about where we are in 2024 in treating IBD is that we still have not exhausted all of the potential drugs that are potentially in existence to treat this condition. There are more and more being studied in clinical trials now. And so if patients are interested in those, then great, we can get them set up for that. And in terms of what's coming down the pike, um, you know, a lot of the drugs I mentioned that have shown good promise in like Skyrizi, for instance, with Crohn's disease, beating out Stelara in that sequence study. There's another drug like it called Tremfya that is already on the market for other autoimmune conditions. And it's showing very good promise for ulcerative colitis. And it's nearing the end of its process to get approved. So sometime in the not too distant future, you will see that Tremfya will probably be FDA approved for ulcerative colitis. And it'll be the fourth one in that category of drugs that can treat ulcerative colitis. But its data does look very good for it to be maybe the best of those four. So we'll see how things go with that. But that's just one of many other drugs that are currently being studied and are in various, phases, phase 2 or phase 3 of their clinical trial, to eventually determine is this a winner? Does this work? But besides rolling out more and more drugs that are all again getting compared to placebo, we as prescribers want to see more and more data of head-to-head drug studies, and so that's where I think there a lot of attention is being put, so that we can take that information and then be better equipped to kind of narrow down which drug should we put someone on.
Well, that makes sense because now there's so many. I mean, how do you decide? And, you don't wanna just throw darts at a wall. So I love that approach. I love that they're doing the head-to-head studies. With this information in this episode. In closing, could you shed some light or give some tips on how patients can effectively communicate with their healthcare providers to ensure that they're getting the best care and how, and making these shared decisions so that the patient doesn't feel like they're being told what to take and the doctor doesn't feel like they're not getting enough information from the patient to make that, most educated decision together?
Right. So I think what is helpful for patients, to tell me is, hey, listen, I've heard of such and such a drug. What are your thoughts on that? These drugs are advertised via commercials on TV a lot. They're in magazines that they may be flipping through in the waiting room, or they may have heard about it through friends of theirs that are on it. And so bringing, I think most folks are open to hearing what would you be interested in trying? Because, like you said, it's a shared decision making process. And so we're not always taking this paternalistic approach and just saying, this is what your disease now commands to be taken. In some cases, we are in that boat. We're like, hey, listen, it's a no brainer. This is the next thing for you to take. I really strongly advise it. And, there's just no point in kind of deliberating otherwise. But when the sky's the limit, like you said, you have 10 different options to pick from. Tell me, have you heard anything about any drugs? Is there any ones you're particularly interested in trying because you've heard good things about it? You have somebody that's on it. Bring that information to me. So I think patients are, they tend to sit back and wait and see what the doctor has to say. And a lot of times patients will say that to me, say, hey, what would you recommend? I'll do whatever you want if you think is best. What would you do if it's your family member in this situation? What would you give them? A lot of times those questions get positioned to me, and I'll tell them, my rationale. But even before getting to that point, if there is something that you have heard of and you want to inquire more about it, because we may not ever get to that drug in our first conversation. It may be something that I'm aware of course, but it wasn't really the first thing I said. You can bring it up and we can talk more about it. And I can say, you know what, that's what you really want to do. I'm not opposed. I don't think it's the first thing I would do, but I'm okay trying it. If you've heard good things, or if you've had experience, you have some relative that's on it and liked it, let your doctor know that information, because that may help make this conversation go easier and quicker. Just hearing what you have heard about, and make me aware so we can talk more about that.
No, this is great. Well, Dr. Crocker, it's been such a pleasure to have this conversation with you today. I hope for our listeners that this has been helpful. Again, we plan some follow-up episodes that specifically talk about other factors in IBD management, such as dietary or behavioral health related, stress related interventions that also help as part of the overall management. But thank you to the American College of Gastroenterology and the Patient Care Committee for collaborating on this episode, and we look forward to next time. Thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.